So welcome everybody. We're going to go ahead and get started today for our Family Medicine Grand Rounds. Today is October the 4th. The event code, I put it in the chat and I'll put it again, but if you need it, it's 216047. But if you have any questions about your CME, please make sure that you either contact the CME office or you are welcome to contact me as well, Nicole Rubio. And then also for those that are claiming their credit, just make sure that you do so before midnight tonight. Next slide. So we want to thank everybody. We're going to go ahead and ask you to mute your microphone if you haven't already. And we would also like to ask that you are attentive and engaged in the session. And then I will also be putting in the chat box again here towards the end of the session, the evaluation form. If everyone could please help us out and provide your feedback on the session for today. I'll put that in at the end of the presentation. Next slide. And so this is the South Texas Regional Family Medicine Grand Rounds. We are partnered with the South Central Area AHEC, and our mission statement is there for you. Next slide. Those who are wanting to claim their CME credit, if you have questions about the previous presentations you have attended, you are able to go ahead and look up your CME credit through your transcript on the CME website. The information, it's kind of hard to see there, but it's cme.utesca.edu if you do need your transcript. So any questions, you can contact them directly, or you can contact me as well. Next slide. Those interested in AAFP credit, you may need your CME transcript for that, but we do offer 1 credit for this presentation today, and any questions, please contact them again, or you can contact myself. Next slide. We also want to make sure that we do point out to you that we are highlighting the goal of our FCM Grand Rounds presentations by addressing the following nationally established physician core competencies. So you can see those there, but if you have any questions, let me know. Next slide. And so we want to make sure we point out that Dr. Katerndahl has no financial relationships with ineligible companies to disclose. And he's going to present for us trauma-driven life, ASD and PTSD and primary care. So we have Dr. David Katerndahl, who is a professor emeritus with our department, and I will let him go ahead and start his presentation.
Thank you, Nicole. Good afternoon, everyone. Because we have a lot of slides to get through, which I believe will be available to everyone after the presentation, I would ask that people hold their questions to the end so we can make sure we get through everything. Thank you. So the objectives today, I want by the end of the presentation for you to be able to recognize and diagnose trauma-related disorders, to be able to treat these disorders using both psychotherapeutic and pharmacologic approaches, and to be able to monitor treatment response and complication risk. Now, I want to start by sharing a recently published study. This was done among primary care low-income patients, and what they found was very high levels of PTSD-related symptoms were very common. And as you might guess, they were predicted by having adverse childhood experiences or being a victim of intimate partner violence. But what was most interesting was only 5% of the charts had documented a trauma-related disorder. So either we're not detecting these disorders among these patients, or we're not documenting them. So I think it's very important to pay attention to this study. So what about the exposure of trauma? So childhood trauma, as you might guess, is very common. If you look at the different types of childhood trauma, you'll see on this one slide, only 35% of people had no childhood trauma to report. That's remarkable. Some people had as many as 4 different types of trauma or more. And when we look at adults, 90% of adults report at least 1 lifetime exposure to trauma. 50% of adults had experienced either physical, sexual assault, violent death of friend or family member, been a victim of natural disaster or accident or fire, sufficient enough that this could lead to PTSD. And multiple exposures were very common. In fact, the mode, which means the most common report, was 3 different exposures. This is a tremendous amount of trauma that our patients are getting exposed to in their lives. So let's start with trauma. So most studies report around 60% of males and 50% of females will have a lifetime exposure, at least one lifetime exposure. Up to a third of those people exposed will go on to develop acute stress disorder, and 8% of males and 20% of females will actually develop PTSD after an exposure. So let's talk about screening for trauma. So who should be screened? So I recommend patients who have inappropriate anger or repeated multiple nonspecific complaints that you just can't figure out. Those are people you might want to screen. Certainly people who have insomnia with awakenings or nightmares, you need to be looking for other sources of those experiences. So here's what I recommend in terms of screening. So I use questions like, have you ever experienced or witnessed a serious injury or assault? Have you a family member or friend who experienced serious violence? In terms of occupational exposure, have you ever worked in a job that exposed you to serious trauma? And finally, in childhood, I recommend starting with, do you remember everything about your childhood, or have you lost memories of your childhood, since dissociation is a common response among children to trauma. And then finally, do you feel like you might have been abused as a child, even if you don't remember it? So these are fairly non-threatening questions that people may respond to. I just want to show you these are common normal symptoms that people might experience after a major trauma. So you see it's a wealth of symptoms in multiple categories. So these are actually normal responses to trauma. All right, so after a significant trauma, if you detect this in a patient, I think you want to start with education, that they should expect symptoms are going to emerge, and it could be anything on the previous slide. You want to approach it with a psychological first aid. So that's things like frequent contact, engagement with patients, information gathering. What things do they need? What concerns do they have after the trauma? Make sure they're safe and feel comfortable. Offer any practical assistance, information about coping, make sure they're connected with social support. And then you want to emphasize things like self-efficacy and hope. Yes, you have symptoms now, but they don't necessarily have to last. Emphasize things like self-help. So exercise, self-regulation through things like breathing exercises, monitoring their sensory input. They don't want to be overstimulated. And a healthy lifestyle. So make sure they're getting adequate rest and relaxation, an appropriate diet. You should have them avoid alcohol and drugs. That's going to tend to make things worse, not better. All right, how do you manage people after a major trauma? So we want to emphasize, you only want them talking about the trauma if they want to, because we want to avoid re-traumatizing them by forcing them to relive these traumatic experiences. So in the past, we used to recommend things like psychological critical incident stress debriefing techniques. We don't recommend that anymore, because that could lead to re-traumatizing the person. So we don't want to push them into sharing their trauma unless they really want to and they're ready for it. But you do want to monitor them frequently for warning signs, things like insomnia, nightmares, anger, paranoia, withdrawal, isolation, and obviously psychiatric symptoms. Those are warning signs that things may be getting worse. You want them to avoid benzodiazepines. This is going to be a repeated theme in this talk. There are studies that suggest that benzodiazepine after trauma can actually increase the risk of PTSD. All right, let's talk about acute stress disorder. So there's a variety of risk factors here based on the trauma they experienced, prior mental health disorders, low self-esteem, poor coping techniques, lack of social support. All those things are going to increase the risk of ASD here. The prevalence is probably higher when the trauma is an interpersonal assault. And the associated symptoms that you can expect under ASD are things like catastrophic interpretation. So suddenly they may respond in excessive concerns about a simple symptom may mean. Impulsivity, panic attacks are also common in acute stress disorder. This is the DSM5 criteria. So obviously you need an exposure to the stressor, and then you need at least 9 symptoms in the following list that either begin or worsen after the trauma. The duration is 3 to 30 days after the trauma, and that obviously needs to cause distress and is not accountable through another disorder. So how do you treat them? Number one, level A treatment is brief psychotherapy, and the goal is preventing them from progressing into PTSD. Currently, CBT seems to be the most effective intervention here. Generally, we do not recommend medication for ASD, certainly not on a routine basis. And again, benzodiazepines are considered a level D recommendation, so they should be avoided. Now, monitoring, so you want to see people with ASD frequently, and you might consider administering the ASD scale, which is included at the end of the PowerPoints. It seems to be very good at predicting who is at risk for developing PTSD. The positive negative likelihood ratios here are really excellent for a scale. The cutoff score is 56, so above that score, they're at high risk for developing PTSD. So what's the indications for screening people with a PTSD screening instrument? So most people would say you might want to just periodically administer the instrument to somebody with ASD to see if they're developing PTSD. Certainly somebody with ASD who is not resolving their symptoms, you have warning signs symptoms, or they're developing dissociative episodes, these are people you would probably want to administer a PTSD screen to. In terms of screening, so 50% of ASD people will develop PTSD. Symptoms usually begin within 3 months of the trauma, but the time course can be somewhat variable here. So 25-30% will develop PTSD within 6 months of the event. Another 30 to 36% will develop it within 12 months. There's a condition called delayed expression, which means it could be even highly variable. It could be very delayed after the trauma. Although most studies find that some of the symptoms begin almost immediately after the trauma. Yes, they may not meet criteria, but there's some symptoms that come on quickly. The 2 instruments I would recommend are either called the SPAN or the PTSD. They're both very brief. They're 4 questions because they're just screening instruments. So their likelihood ratios really are in the moderate range for a positive likelihood ratios, and really have only a small effect in terms of negative likelihood ratios. So again, they're moderately good at if they're positive, they're not so good if they're negative. So what are the risk factors for PTSD? So the DSM puts them in 3 categories: personality risk factors, environment, and stressor risk factors. So personality, if you're a victim of prior abuse, if you have pre-existing psychiatric problems, if you have maladaptive personality types, And if you already have low self-esteem, you're at more risk for developing PTSD. If you have low SES, family history of things like anxiety and neuroticism, you're also at high risk. But probably the stressor is perhaps the most important thing. So the traumatic event itself, was it life-threatening, caused physical injury? Did you have a sense of horror or helplessness during the trauma? Did you dissociate during the trauma? From a military experience, were you a perpetrator of injury? Did you actually kill other people? Those are high-risk developments. A relatively new development is recognizing obstetrical trauma as a precursor to PTSD. So preeclampsia, miscarriage, and intrauterine death have all been found to be risk factors for development of PTSD. And then post-trauma, there's also risk factors. So people who lack any significant social support are at high risk. Poor coping, prior ASD, other losses or traumatic events. And then there's triggers. Let's talk a little bit about triggers that you might expect to see in patients. So there's external and internal triggers. So sight, sound, smells, people, places, things, dates, nature, news coverage. So I've had patients say, I watched something on TV and suddenly I started to have flashbacks. Confining situations, relationships, arguments, medical care, funerals, almost anything can trigger somebody in PTSD. But there's also internal triggers. So things like discomfort, sensations, emotions, feelings about others, all those things could trigger things like flashbacks. All right, let's talk a little bit about DSM5 criteria. So they're across these categories, and I want to go into them a little more detail. And one thing that's kind of significant is there were some major changes in the PTSD criteria from DSM-4 to DSM-5, more so than a lot of other disorders. So let's just summarize some of the changes. So one, the traumatic event. So the recurrent occupational exposure was added. That was not in DSM-4. But emotional response to the trauma was dropped. That's no longer necessary. They rewrote the re-experiencing criteria. Developmentally appropriate criteria was added in the case of children. You need to keep that in mind for childhood exposures. Avoidance criterion was actually split, so there's now 2 criteria in place of only 1. And then arousal criteria was revised and had things added to it. And finally, there's an ongoing discussion of whether we should change the title of post-traumatic stress disorder to post-traumatic stress injury, because there was a feeling that the disorder part was a barrier for, mostly in the military, for them to seek treatments. So let's break this down. So letter A, actual or threatened death, serious injury, sexual violence in at least one category. So either directly to you, you witnessed it, you learned about the traumatic event to families or friend. In cases of actual or threatened death, the experience must be violent or accidental. And then repeated exposure. So people who work in an emergency room, EMS people, those people are actually exposure at risk to develop PTSD from that exposure. Secondly, at least one intrusive symptom after the events occurred. This could be flashbacks, nightmares are very common here. C, avoid at least one avoidance of stimuli. So avoiding things that thoughts or memories of the trauma, avoiding external reminders, things that are triggers can also fit in this category. D, are at least 2 negative cognitions or moods associated with it. And I want to emphasize the second one here, negative beliefs, expectations. So it's very common for people to develop paranoid ideation around this, around PTSD. E is at least 2 alterations in arousal or reactivity. So anger problems, violent outbursts, very common in PTSD. And then under hypervigilance, so it's very common for people to say they see shadows out of the corner of their eye. I think this is a manifestation of their hypervigilance. The duration has to be at least more than a month. Obviously, there has to be significant distress or impairment. I do want to mention dissociative symptoms are actually not at all uncommon in PTSD. Hallucinations typically are pseudo hallucinations, so they can recognize that if they're hearing a voice or a sound, it's in their head. Dissociation has a bigger effect on the person than psychotic features do. Dissociation often leads to negative cognitions, and there is a serious risk for auditory hallucinations in these people. PTSD is associated with conversion disorder and conversion blindness, so those sensory abnormalities are not at all uncommon here. And there's a condition called sensory defensiveness that is present in about 80% of people with PTSD. And so this can lead to things like misinterpretation of sensory events and social withdrawal and usually eating habits. Their symptoms may wax and wane with stress and environment. It can impact their self-esteem and safety in relationships. They can even develop what's called anosognosia, which is a denial or an unawareness of neurologic deficits. So it can really have profound effects on people. This shows the prevalence of different symptoms. And as you see, most of the symptoms on the list are at least 50% or more. Only things like restricted affect and flashbacks are under 40% here. So PTSD really adversely affects relationships here. Poor marital adjustment is common. And if parents have PTSD, it can really affect the child. So perceived parenting is perceived to be a challenge in these people. Poor parenting behaviors, they are common. There's an increased risk of physical abuse and child anxiety. And finally, because of numbing and avoidance in the parents, their perceived satisfaction in parenting goes down, and there's an increase in parent-child aggression. All right, what about therapy? First of all, there's too much evidence. So this is one of those cases where PTSD has received a lot of attention. There's been a lot of studies in recent years. And as you see, there's lots of guidelines. So it can be challenging sorting out what's the truth, what are the best therapies. So let's start by looking at some systematic reviews, and we'll focus first on pharmacotherapy. Medication effects have been shown that medications can decrease symptom severity, depression, and disability. Response is about 60%. Full remission is uncommon, 20 to 30%. There's only a couple of FDA approved medications for PTSD, that's paroxetine and sertraline. But there's lots of evidence that other things are effective. Medication comparisons vary somewhat from study to study. So one systematic review felt that paroxetine was better than sertraline and fluoxetine. Another one felt that sertraline, venlafaxine, and nifazodone were better than other medications. Again, a lot of variability here. Augmentation, so one review said that risperidone seemed to be effective at augmenting the SSRIs in PTSD. One interesting thing is among people who had responded to antidepressants, if responders stop their antidepressant and discontinue them, they have a threefold risk of relapse within 1 year. All right, let's look at psychotherapy and systematic reviews. So there's a number of effective approaches that seem to be endorsed by a variety of systematic reviews. So trauma-focused CBT, both individual and group, seem to be effective. Stress management, EMDR, which is eye movement desensitization and reprocessing. All these things seem to have good evidence for them. There's some novel approaches. So mantra therapy, in one review, seemed to be more effective than stress management and problem solving. An interesting finding is that written exposure therapy seems to be equally effective to cognitive processing, but the written exposure therapy can be done in fewer sessions, so it may be more cost effective. Comparisons is, so one systematic review felt that trauma-focused CBT and stress management seem to be more effective than other psychotherapies, and other ones felt that EMDR was more effective than trauma-focused CBT. So again, some variability here. Group CBT, there's a general consensus is probably only adjunctive and is not as good as the other forms of therapy. All right, what about combined psychotherapy with pharmacotherapy? So there's not as many studies here. So one study, one systematic review looked at combining SSRIs with prolonged exposure or CBT, and they felt that there was no difference from monotherapy. Another one found that psychotherapy was equally effective as combined therapy, but these were both better than pharmacotherapy alone. American Family Physician has published a couple of reviews in the last 10 years. So the most recent one said level A therapies was CBT, was the only level A therapy, but under category B, we had a variety of both psychotherapeutic approaches and pharmacotherapy, and category C included a variety of other things. Warner's review from 2013 felt that first line could be trauma-focused CBT as well as SSRIs and NSRIs, and they felt prazosin was adjunctive. They did note to avoid benzodiazepines, and the risk here is twofold. So one is there's already an increased risk of substance abuse with PTSD, and so benzos should be avoided for that reason. But also there's studies that suggest that if patients are on benzos, that the benzo may compromise their response to psychotherapy. So that's another reason to avoid it. And then category C in this review felt to recommended avoiding antipsychotics, but that was at monotherapy. So, all right. So there's been a variety of guidelines, and this is 10 different guidelines I found since 2004, but that includes 2 guidelines with revisions. What's interesting is they've actually done some studies comparing the benefits of the different guidelines. So this study was very interesting. So it actually used the guidelines and used independent information to say, well, how good is this guideline? What kind of a response or impact should this guidelines recommendations have based on independent evidence? So what they found was, in terms of psychotherapy, under trauma, no psychological debriefing seems to be accepted among these guidelines. Under ASD, the trauma-focused therapies were recommended, and for PTSD, trauma-focused therapies, including EMDR, as for all these things were first-line therapies. And they're really, in terms of second-line therapies, there were none under trauma exposure or ASD, and a lot of variability under PTSD. Under pharmacotherapy, first-line pharmacotherapy, there's nothing recommended for trauma and ASD, and SSRIs were recommended as first-line therapy for PTSD, And again, second line therapy under PTSD, high variability here. So when they looked at how well these guidelines performed, the guidelines that advocated trauma-focused therapy over medications as first-line therapy outperformed the other guidelines. In terms of second line, again, there was no consensus, no consistent performance outcomes here, benefits here. So I think the guidelines that emphasize trauma-focused therapy as first line are definitely outperforming. All right, so what about the patient who comes in and says, oh, can I just take a pill? I don't really want to talk to a therapist. Can I just take a pill? So remember what Taylor Swift taught you, right? Band-Aids don't fix bullet holes, all right? So yes, we're not going to force people into therapy, but we're never going to completely heal them without it. And so that's a message that people do need to hear. All right, what about symptom-specific treatment? So there are medications that will treat individual symptoms. So people who have a lot of aggression, a lot of violence outbursts, you can think about mood stabilizers and antipsychotics. There's some evidence that carbamazepine may cut down in flashbacks. Propranolol may be useful at re-exposure distress. In fact, there was a recent study that found that for people with PTSD who experience a lot of emotional upset when they're in psychotherapy after one of their psychotherapeutic episodes, that if they take propranolol prior to the psychotherapy, that cuts down on some of their distress during the therapy. And so you might consider it for those people. Psychotic symptoms, if they're scary, they're dangerous, antipsychotics can be useful. How about suicidality? So you might consider lithium. Remember, lithium is the only psychotropic that has good evidence that it reduces suicidality in general. There is a study that suggests omega-3 fatty acids may reduce suicidality in PTSD patients. Whoops, did I go past one? Yes. All right, I wanted to spend a little time talking about nightmares. People who have been with me in psychotropic clinic know that I focus a lot on this, and there's reasons that I do, because nightmares can have a really serious impact on people with PTSD. So number one, they're associated with increased PTSD severity. The suicide risk is higher among PTSD patients experiencing nightmares. And that the nightmares can actually persist even after the other PTSD symptoms seem to improve. Medication-wise, so the most studied medication here is prazosin. And what you want to do is the minimally effective dose is typically 3 milligrams. So you want to titrate them up to 3 milligrams over a 1-week period if you're starting prazosin. The recommended maximum dose that I've seen is 20 at bedtime and 5 in the morning. Seems a little illogical to me that you would want to give 5 milligrams in the morning to somebody who is experiencing nightmares. Terazosin is an acceptable alternative. You want, because it's got a long half-life though, and it's a hypotension risk, you want to start low with this medication. So I usually start 1 to 2 milligrams at most, but you can go up to 20 milligrams. And a distant third recommendation is cyproheptadine here. There are some psychotherapeutic approaches. I think the one that has the best evidence is called imagery rehearsal therapy. There are some other approaches that I think have potential, but I don't think we have great evidence yet for them. What's the course? What can we expect the prognosis to be in PTSD? So it's very much affected based on how close to the event, the traumatic event we are, how long the traumatic event occurred, and how intense it was. As the patient ages, arousal, avoidance, and negative symptoms seem to naturally decline and improve. but health perceptions may actually worsen over time if we don't address the PTSD. Spontaneous resolution can occur, and about 50% of people will recover within 3 months of onset of their PTSD, even without therapy. In those receiving therapy, it's not a quick fix. So the mean duration is about 36 months here to recovery. Predictors of a good prognosis. So early and ongoing support is a strong predictor of a good prognosis. Rapid onset of treatment. So if you get into therapy quickly after the onset of the event, that's going to bode well. Avoidance of re-traumatization. That's why we don't want to force people to relive the experience unless they're ready to. Absence of mental and substance abuse disorders. And then repression of anger is important. So those people who not only experience anger, but are able to repress that anger and don't let the anger outburst control them, actually have been shown to have decreased mortality, decreased PTSD symptoms, and decreased disability. So this actually bodes well for them. What's our role as primary care physicians? So again, it's kind of across the board, right? So we need to be screening people and making the diagnosis, certainly providing education at every step of the way, monitoring symptoms and comorbidities. And I included an instrument called the PTSD checklist, the PCL5. So it's been shown that a score of greater than 33 on this is an indicator that this person needs to get into treatment. A clinically significant change is a change of about 10. So this is good for monitoring people through therapy if you want to use it that way. Family physicians, there's no reason we can't be involved in treatment and certainly referral. And most people that have commented on primary care and PTSD recommend that we be the team leader and really coordinate things. All right, summary of my recommendations. So number one, low threshold for screening, both for trauma and for PTSD. Avoid benzos, and hopefully you've gotten that message here. Every step of the way here, benzos are not beneficial. They can produce a lot of harm. In terms of acute trauma, focus on psychological first aid, meeting their needs, being supportive, but you want to monitor them for warning signs and refer in the first sign of trouble. Acute stress disorder, get them into brief psychotherapy. You may be able to prevent them from going into PTSD. And again, you want to monitor them for warning signs and refer. In people who actually have PTSD, all patients are going to need at some time trauma-focused therapy. I think you need to just get that in your mind. I would communicate that to patients, even if they're not ready for it yet, that they need to try to remember that at some point this is going to be good for them to do. You want to assess and treat nightmares, and I recommend prazosin as your first choice. You want to assess and treat anger problems. Both antipsychotics and mood stabilizers can be useful here. Assess and treat psychotic features. So remember, paranoia is common, hallucinations are common. I don't think all hallucinations need to be treated. So sometimes people will say, I hear my name being called. Those things don't need to be treated. But if they're scary hallucinations, if they're being told to attack people or that people are out to get them, I think those people probably need to be on antipsychotics. And then monitor them for substance abuse and suicidality, because those are both very high risk. What are the indications for referral to psychiatrists? So number one, if the patient requests a psychiatrist, I never stand in the way. They need to see a psychiatrist. If you're in a situation where you cannot access trauma-focused psychotherapy, that's somebody you might want to refer. If they have concerning symptoms, so obviously suicidality, homicidality, dissociation. So remember to be sensitive to the possibility of dissociative identity disorder. We have seen people in psychotropic clinic that we think have this, and those people need to go to psychiatry because they're beyond our pay grade. If they're actively abusing substances, I think those people need to be in with a psychiatrist. And if you just feel unsafe, because these people can be very aggressive, they can be very paranoid. If you feel unsafe, they need to be referred. All right, so summary of main points. Number one, trauma. Exposure is common. I think hopefully the evidence supports that here. Psychological first aid and monitoring warning signs to pick up on who needs to go to psychotherapy. Again, avoid benzodiazepines. Patients with ASD, the onset is within the first month after trauma. Brief psychotherapy can prevent these patients from progressing. Avoid benzodiazepines. Patients with PTSD, that will typically begins months later after the trauma. All patients at some point will probably need trauma-focused therapy. SSRIs and NSRIs can help. Consider treating the specific symptoms as needed. And again, avoid benzodiazepines. All right. So I ran through that pretty quickly. So who has questions?
Dr. Cavendale, this is Byron, Dr. Hepburn. That was an outstanding presentation. Can you hear me, Dave?
Yes, I do.
Great. And I hope the residents keep the copy of these slides, because obviously it's going to have a lot of relevance as they move forward in their professional journey. I would just a few comments. I'd be mindful there are certain professions where, and health is one of them, that people are reluctant to seek assistance or even acknowledge that they have these concerns. First responders are another community. Certainly the military is that way. It's a culture of, I got this, I can take care of it, when often at times it progresses to the point where it's very dysfunctional. So be very mindful of that as you move forward in your journey as a resident, physicians. As a family physician, don't forget there's an impact to the spouse or significant other and the children too. So there are adjunctive therapies, as Dr. Katerndahl mentioned, adjunctive therapies, couples therapies and so forth that can help with that as well. And then in some of these patients, they're going to be polytrauma patients. They're going to have physical injuries, significant physical injuries, comorbidities with these emotional issues that Dr. Katerndahl very well addressed. So that adds to the complexity of your patient there that you'll be caring for. But be mindful of that intersection with a TBI patient or the abdominal trauma patient from motor vehicle accidents or violent crime or trauma. So orthopedic injuries are very common as well. So, and that's where the challenge comes in when they get put on narcotics and some of the other medications concurrently. So just be mindful of those other things as well. But that was a great talk, Dr. Katerndahl. I appreciate you giving this for our residents. And there are a lot of great organizations here in San Antonio to help with this, to assist with these communities, so these individuals and families. So thank you so much.
Those are all great points, Dr. Hepburn. Thank you for making them. And I want to emphasize one point he made is that people frequently don't volunteer these things. So you really need to have a low threshold for screening people and asking them about it.
Dave, it's Mark. Just a couple of questions. You might have said this, I missed a few minutes of the talk, but for patients that say are more like a near miss than a direct trauma, like they get out of the car just before the train hits it, or for somebody who witnesses somebody else who's had a bad experience. I know saw a patient who was in World War II in the Philippines and saw a bunch of starving children as an example. So are there any things that are different or the same with regard to that sort of situation?
I'm not familiar that those are any different. Those are certainly perfectly appropriate traumas to lead to PTSD. Yeah, absolutely. Near misses qualify.
Thank you.
Yeah, there are a number of publications. In fact, one of them is great ones from Yale on emotional trauma, emotional injury, if you will, and what you just talked about, Dr. Nato, where this physician or whatever can care for those kids. And we've seen that with these recent deployments where very capable providers in Afghanistan or Iraq knew they couldn't do anything for that child that's by the side of the road. So it's very stressful. So I'm glad you brought that up.
Thank you, David, for a great presentation. One of the issues that I think you mentioned in passing is that sometimes it can be blocked or hidden for many years, and then they sort of show up in a different way. I had a patient who I think fit that definition in the sense that he was highly functional, very well adapted, but he had a history of working in sort of some of the hidden wars in Central America, and he had a lot of that guilt and sense of difficulty come back to him and manifest in terms of difficulty sleeping and all that. So I guess I think you make that point. I just want to emphasize that sometimes people who are out of the blue just become dysphoric. It's important to always ask, because it might be under the surface. And in this particular patient, I even knew socially and had no idea that that was part of his. But once we addressed it, then he was able to get better.
Yes, remember the delayed expression, that's a real phenomenon, that people could go extended periods of time without significant symptoms and then suddenly it's triggered. Absolutely.
I don't know if you're able to see the chat box, Dr. Katerndahl. So I have a few questions that have come in. One is, do patients have PTSD need lifelong psychotropic medications? And then also at what point do we decrease or stop medications?
All right, so I think the answer to the first question is dependent on whether they get into the trauma-focused psychotherapy, all right? Because remember, the medications, you're putting the Band-Aid on the bullet hole, you're not healing the wound there, all right? So in fact, one thing we do in psychotropic clinic is I emphasize with people, look, 5 years from now, I don't want you still sitting here having to get your medications because we never addressed the basic trauma. So I think that's a selling point to patients to get into psychotherapy, is so that eventually they can get off their medications. So I think, I don't think there's a definite time frame as to when you go off medications. And again, I think until they're willing to address the trauma through psychotherapy, my guess is they're going to continue to need medications.
To add on to that, Dr. Katerndahl, this is Byron again. You know, for the residents, there are a lot of organizations out there that have really, they're very enjoyable retreats, horseback riding, kayaking, fishing, whatever it is. You know, take your husband and wife to resorts or whatever. And that may be adjunctive. It certainly makes them feel good. But to Dr. Katerndahl's point, the real substantive therapy needs to take place, whether it be the cognitive-based therapy, the other modalities that Dr. Katerndahl gave a great overview of a few minutes ago. So you can, for your patients, make them aware that they're available and they are good, they're helpful, but they're not the definitive answer. They have to snug down and do that cognitive-based therapy or exposure-based therapy, whatever is being used by your team. And I'm sure Dr. Obeid has some great tools in her kit bag as well. Thank you.
Any other questions?
Dr. K, if you have someone who you want to start like prazosin or terazocin on for nightmares, but they're hypotensive,
Okay, Sam, you're kind of breaking up.
do you avoid it or do you just start a low dose? How do you kind of go about that? Oh, sorry.
Can you repeat?
If you have a patient, can you hear me?
Yes.
Okay, if you have a patient with nightmares and you want to start like prazosin or terazocin, but they're baseline hypotensive, do you avoid the medicine or do you just start at like a low dose and see how they tolerate?
So if their baseline is hypotension, I'd be very anxious about starting an alpha blocker, period. Certainly you wouldn't want to start terazosin because it's got a long half-life, so that's going to be a problem. The nice thing about prazosin, it's got a relatively short half-life, so they take it when they go to bed, and by the time they get up in the morning, it's largely out of their system. So it's going to be safer from a hypotension standpoint. But we've had people that we had to take off prazosin for daytime hypotension, even so. So that's somebody you may want to start with cyproheptadine, even though it's not nearly as good as the alpha blockers. It might be safer in somebody who chronically is hypotensive.
Okay, thank you.
Mm-hmm.
Any other questions or comments from anybody?
All right, well, thank you, everybody. And I think Nicole said she's going to send everybody the PowerPoints.
Yes, I'll send it. There is someone on here listed as IPS. I'm not sure who that is. So I'll send it to the family medicine listserv. Everybody should be on that, as well as those in attendance today. But thank you, everybody, for joining us. And then also I've already put the evaluation link in the chat box, but I'll send that along as well. So thank you very much, Dr. Katerndahl. We do appreciate everybody joining us.
Bye, everybody.